Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. Hello, I'm your host, Dr. Prasad Dandekar. I'm an oncologist and I head the radiation oncology department at Sir H. N. Reliance Foundation Hospital in Mumbai. In today's episode, we have Dr. Amit Rauthan with us. He is the head of medical oncology at Manipal Hospital in Bangalore with special interest in precision oncology. We have had our conversations before on precision oncology with Dr. Sevanti Limaye, and today we have another star medical oncologist from India to talk about something which sounds very confusing, but is actually life-changing for treatment of cancer patients. So we are talking today about NGS or next generation sequencing. We are talking today about NGS, next generation sequencing, with Dr. Amit. Welcome, Dr. Amit. Thank you for joining us today.
Thank you, Dr. Prasad. It's a pleasure being a part of your meeting and this wonderful endeavor of information and passing more and more information about oncology. So thank you for having me here.
You're welcome. You're welcome. So, Dr. Amit, I'm very curious about what made you join oncology, because you're a senior medical oncologist. Back when you must have decided to become an oncologist. Oncology was not the fancy thing to do, was it?
Yeah, I agree with you fully. This was 25 years back when I joined in oncology, and that time it was all about oncology being a dreadful disease, survival being very poor. But still there were a lot of challenges, and that's the time when we got into oncology. And it as time passed by, we kind of understood how interesting is it. You can make a real difference in patients' lives. And as time passed by, all these new advances started coming into the field. We saw all the sequencing coming into the picture. We saw tumor mutations being understood. And we understood later, a decade ago, immunotherapy came into the picture. And with all these advances, oncology has become a very, very, I would say, a very exciting field. We are changing how we treat patients, and we are changing how patients live through their journey of cancer. And I think there's a lot of change and there's a lot of excitement in oncology now.
Yeah, absolutely. I remember in 2001 when I joined Tata Hospital, or I sort of got the seat. My first question to the consultants there was, do you think there is any future in this branch? And here we are today, like really struggling to maintain our quality of life because we're just overwhelmed with work, and there are so many cancer patients, unfortunately. The incidence has shot through the roof. But the change that I see as an oncologist is, initially we had patients who came with some lumps and bumps, and then, we didn't know what it was. And over a period of time, all the biopsy techniques improved, and we started taking tumors out. And initially it was a surgeon who would cut open the tumor, take the tumor out, and then the pathologist would say, oh, is this cancer or not cancer? Then we started classifying cancers into, oh, is this type of cancer versus that type of cancer? And then came all the immunohistochemistry and markers. And now we are talking about something which completely sounds alien to us. We take a sample of the blood, and then the medical oncologist tells us which treatment would work for you. This is what future looked like back then, and we are here now. The future is here. So how has these things changed over a period of time? What has happened?
So when we were starting off, from the medical oncology point of view, all our treatments were based on chemotherapy alone. And this was, the surgeons took it out, radiation oncologists gave radiation, and then when it came to medical oncology, it was all about giving chemotherapy. And the whole hope was chemotherapy is going to wipe out all the cancer cells which are left in the body. After surgery, you will kill the microscopic cells, and that will probably give you a possibility of complete cure. And it did happen to a lot of patients. But again, in the stage 4 setting, chemo could do only this much. You increase survival a little bit, but it always came with a lot of quality of life issues, because we know chemotherapy was a blind therapy. You're giving IV injections and they're going to kill multiplying cells, but they kill not only multiplying cells but also normal cells. And that's the reason chemotherapy got the name of having too much side effects. And that's why everyone's scared of chemotherapy even today. When you just say chemo, and everyone said, oh, I'm going to have a lot of side effects. But we moved into an era of learning about how cancer develops and how these changes happen. And with that is this new era of precision oncology is what we keep talking about. And I think these are wonderful changes which are happening.
Yeah, I think NGS started becoming more of a buzzword only a few years ago. But I remember around 12, 13 years ago, representatives from a particular lab, I think Datar it was, who would come and talk to us about, we can do liquid biopsy. And at that time, I would tell them, but, okay, fine, you do liquid biopsy and you take the tumor, identify that there are tumor cells in patient's body. And then what do you do? And they had no answer to that. And I would shoo them away saying, we are not going to do any of these tests. And things have changed quite a lot from that particular conversation to today, where we are choosing to do NGS and liquid biopsies in many patients. So, from the point of view of our viewers, can you break it down for us? What is NGS?
Right. So to understand NGS, we say this is next generation sequencing of a tumor. Now, to understand what this is, one needs to really go back to see why cancer is developing. So when we say cancer, what we're meaning is there's an uncontrolled multiplication of a normal cell which starts multiplying uncontrollably and doesn't stop multiplying, and then it grows locally and then it spreads and metastasizes and becomes a stage 4 disease. Now, what we came to understanding is why is this uncontrolled multiplication happening? And that's where we came down to understanding in the cell we have genes which are regulating the whole mechanism of multiplication. So we have these proto-oncogenes which actually are causing multiplication to happen, and then there are tumor suppressor genes which are stopping multiplication to happen. And our body is running in a mechanism with a very fine balance between these proto-oncogenes and tumor suppressor genes. Now, if there's an insult which leads to cancer development, which could be an insult like smoking or environmental factors, what it does, it's affecting some abnormality in these genes, and these proto-oncogenes then get mutated or get abnormalities into them, and then they start multiplying. They become oncogenic, and then they don't stop multiplying. Or the tumor suppressor gene gets hit, it gets mutated, and it doesn't do its function, and then they don't stop multiplying, and then cancer keeps growing. Now, with this understanding, what came out is we were able to identify what are those genomic hits which are happening on the gene, and these came out to be understanding gene mutations. I think we heard it was almost 25 years ago when we started hearing more than that, when we started hearing about BCR-ABL as being the mutation or the abnormality which was leading to chronic myeloid leukemia. And I think 25 years ago, we heard about EGFR mutations leading to lung cancer. And these are the hits which are happening on the genes which are leading to cancer development. Now, the thought was, how do we identify these mutations? And how do we kind of know that these are the ones which are driving the cancer development? And with that understanding came in the whole way of looking at tumor profiling and understanding these mutations. And this comes into the next generation sequencing. So what happened, I would say 15, 20 years ago, when we just started doing these tests, it used to be the biopsy, as you mentioned, identifying we have a lung cancer, suppose we have an adenocarcinoma. Now we knew EGFR is one mutation, so we had the test, which is the PCR test, and with PCR test, we kind of identified this is the EGFR mutation, and this is driving this cancer. So we could target them by using anti-EGFR therapies which came in. But then this is one abnormality. But what we learned is it's not one abnormality. There are multiple gene abnormalities happening simultaneously. Some of them are driver mutations which are driving the cancer. Some are passenger mutations which are there in the background as the cancer is developing. And then came, how do we identify all these mutations by doing a tumor profiling? And that's where the next generation sequence technique came in. And then what that means is you biopsy the tumor, you take the tumor tissue sample, and then you send it to these labs where they are going to extract the tumor DNA from there. And then that tumor DNA is going to be sequenced, and they're going to study them for all these mutations simultaneously. And with that, they identify which are these mutations which are driving these cancers. And with that, we get the NGS report, which tells us these are the cancer drivers.
So, as I hear, if I were to summarize what you said, you basically are saying that we as humans have, of course, billions of cells. In the cell, we have nucleus, DNA, and genes. And because of either random effects or some environmental factor, some of these genes will then start misbehaving. And that is how the cancer is developing. And when we are talking about NGS, we are actually talking about the tumor. So that we take the tumor out, we look at it, and we say, oh, what has gone wrong in this tumor, in this individual, and which genes are actually sort of misbehaving, and can we have some drug to counteract that?
Absolutely. Yeah, you put it absolutely right. And I think the best way to understand NGS is probably putting in the context of the cancer where we use it maximum is lung cancer. So if you think of lung cancer, we earlier divided them into two types. We said non-small cell lung cancer and small cell lung cancer. Then we said non-small cell cancer could be adenocarcinomas and squamous cell carcinomas. And then we treated all the adenocarcinomas exactly with the same chemotherapy regime. But now with NGS, we biopsy that tumor, we find out an adenocarcinoma, and then send that tumor biopsy to one of these NGS labs, which sequences the tumor and then tells us, divides these adenocarcinomas into almost, at today I would say 9 different types of adenocarcinomas. We say it could be dependent on EGFR mutation. It could be an ALK rearrangement, it could be a ROS1, it could be a RET, HER2, MET, RET. A lot of them are now identified. And now we say there are 9 different types of adenocarcinoma lungs. And the main advantage is now we have targeted therapies for all of these individually, which are different medications. So now I don't need to give that broad chemotherapy to this group of patients. For an EGFR mutation, I can give them a therapy which is an oral tablet, which is against the anti-EGFR mutation. For an ALK rearrange, we have these wonderful tablets, which are ALK inhibitors. And these are oral tablets again, which treat these patients very, very well. We have seen how the survival is dramatically changed with these ALK inhibitors, and the side effects are also completely avoidable. You don't really need to give ALK inhibitor patients chemotherapy these days. So that's the way NGS is changing our whole look about cancer treatment.
Yeah. I mean, when we started training, lung cancer, even when it was not metastatic, was considered almost like a death sentence that, if a patient has lung cancer, then you know that they're not really going to do well. And now we have metastatic, stage 4 lung cancer patients doing so well. I mean, I have patients who are on EGFR therapy, and then something develops. We give a little bit of radiation here, a little bit of radiation there. We change the therapy a little bit, and they go on and on for years. And that's just wonderful to see how precision medicine is really changing the way oncology is being practiced.
Absolutely. I think this whole way of kind of identifying that EGFR mutation or that ALK rearrangement, targeting it has really changed how we have seen our lung cancer patients. I still remember a couple of, if you go back 15, 20 years, we hardly used to see a year survival. We said if we got a 1 year survival in lung cancer in stage 4, we have done very well. And it used to be so sad to see that happening. We used to give so many chemotherapies, so toxic chemotherapies, and eventually we used to just get about a year. If we got more than a year, we said, oh, we have done wonderfully well. And now, today, an EGFR, we would say we're going to treat for multiple years. And ALK, the median survival has become more than 5, 6, 7 years now. So that's amazing to see how this survivals have improved so dramatically. Unfortunately, we don't have targeted therapies for every subtype mutations. All the subtypes don't do so well. It's some groups, we say the non-smoker mutation profiles like EGFR, ALK, ROS, and RET, which do really, really well. But there's the other group, the BRAF, the METs, which do better, but not as well as these non-smoker driver mutations.
Yeah, absolutely. So, from a patient's perspective, if suppose somebody has a cough, they go to a doctor, do a chest X-ray, the doctor says, okay, let's do a CT, they do a PET scan, they detect that, okay, there is lung cancer, and then we do a biopsy. So, what happens after that? That biopsy, suppose their doctor says that you need to do NGS. What happens to that piece of tumor?
Yes. So when we do a biopsy these days, we always tell our intervention radiologists, please give us additional blocks, give us 2 blocks. So one block goes in for the classical histopathology and the IHC to identify the adeno and the squamous carcinoma. Suppose it's lung. Now, the other biopsy block is sent to the NGS lab, and that block is run through. So once we have identified the cancer, then we say send that block and test it. And that block is which is put up for NGS testing, where they are doing the massive parallel sequencing of all these genes. It could be a limited panel test where they're looking at about 12 to 15 genes. It could be a broader panel test where they look at about 55 genes, or it could be a comprehensive NGS where they look at more than 300 plus genes. But any of these tests are a must before we start treatment for lung cancer. So one form of sequencing is a must. This sequencing then generates a report which tells this lung cancer is being driven by this mutation if we find a mutation. Now, in lung cancer these days, we find at least in 50% of patients we have some actionable genomic mutation. These are called AGAs, or actionable genomic abnormalities, and these 50% would go in a different direction. The rest of the 50%, once the NGS says, no, we don't have an actionable mutation, then these are treated in a different manner.
Yeah. So basically, when we give that lab that tissue, they will sort of, it's almost like opening up their tumor's kundali and seeing what are the details. And then, or maybe, you look at, if you look at, many patients look at cancer treatment as almost like a war. You're waging a war on cancer. So you're getting to know your enemy better. You're knowing their weaknesses and you're knowing where you can hit better. And then you can, rather than just bombarding the entire place with some artillery, you can then focus, okay, this is the weak point and this is what I'm going to target. And that is how we sort of win that war, or at least prolong our win for a very long time.
Yeah, what you say is absolutely that's where the word precision oncology is coming in from. You're moving away from general broad therapies and using a precise therapy after identifying the abnormality you are finding. And it's not only in lung cancer. We are doing this now in almost every cancer. You name the cancer: colon cancer, cholangiocarcinomas, ovarian cancer, gallbladder cancers, breast cancers. We are doing NGS testing in almost every cancer to identify these specific genomic abnormalities, which may help us choose our therapies much better and move to the field of being more precise.
When any new technology comes in and any new test comes in, I always fear that there may be some sort of misuse of that. So, from that point of view, who should actually order NGS and who should read that report?
So one should have, as medical oncologists, we always say, we have to know what is NGS to a complete understanding. And to know an NGS, you need to really understand what is the type of test you're ordering. Then you need to understand what is the type of test the lab is doing. There are a lot of NGS platforms these days. There are a lot of labs doing various kind of NGSs. There are various gene numbers everyone is covering, and there are various abnormalities. We'll hear these terminologies. I am doing a DNA NGS. I'm doing a DNA with an RNA NGS. I'm doing an NGS which is hybrid capture. You'll hear these terms which are very different, and that's where a medical oncologist has to be really trained in understanding these. But the good thing is, the way the field is changing, the way the training is happening, there's a lot of training happening in molecular oncology now. It could be with professional courses itself, having additional training, or it could be specialized courses which people are doing as an extra course to try to get specialized into molecular oncology. And understanding the molecular mechanisms of cancer, and then understanding how these tests are being done, how are these tests different in each way, and how does the interpretation come in. So there are molecular I always get the
I always
geneticists.
also get it wrong. Geneticist.
Geneticists.
We
There
can't
are
even pronounce what they do. I don't know how they do what they do. So complicated.
they do some amazing work. They really do some amazing work. The way they interpret these abnormalities, telling us these are the driver mutations, these are passenger mutations, these are the ones which are targetable, these are the ones which may not be very representative. They do an amazing work. And I think with that report, as oncologists, we need to understand, we need to interpret, because eventually the patient is sitting right in front of us, and we have to answer and look at how best to utilize this report for the patient. Yes, I think you brought up a very salient point when you said there will always be misuse, and the way the test is being ordered or the test is being interpreted. I think this is going to be a learning curve. One is, whenever you treat cancer, there's always that hope you are in. You always keep hoping, I will get an abnormality which I can target. But the reality is, in some cancers you're going to get it really good. Like in lung cancer, you're going to really pick up the rates of pickup are very high, and you're going to have some cancers where you're not going to pick up at all, and you're not going to have anything great new to offer. But so that's the reason, when you start testing more and more, there are areas where you're going to have a lot of disappointments, even for an oncologist and for the patient. So sometimes when you send testing, patients become very hopeful that something new will turn up, and this new will be life saving for me, and that's the hope you are doing it in. But it's not going to be true all the times, or many times it's going to be kind of a report which may show no abnormalities. Sometimes it will show an abnormality which is just a passenger mutation. Sometimes it will show an abnormality for which you don't have a drug for now. And that's the reason why, this is a whole learning curve which is going on, which we are trying to adapt to, hoping to open up new opportunities for patients.
Yeah, I remember seeing a patient with recurrent head and neck cancer, and he was a tobacco chewer and had multiple oral cancers over a period of time, and sort of was reaching the end point. Multiple surgeries, a couple of times radiation, various chemotherapies, OMCT, all of that, and then the medical oncologist advised him NGS, and nothing came up. And so he had some hope left till then that we'll get something can be done, something. But that NGS report sort of made him feel that he's lost that battle completely. Now there is nothing left, and it was a very difficult conversation. And I had not asked for that test, and I didn't even know he had done it. He just came to me with the test, which didn't show anything, and it became a very awkward conversation as you rightly said, that we are hoping for something, and here the patient was saying, oh, I have lost hope now, and it becomes so much more difficult to manage these situations.
No, you're right, Dr. Prasad. I think that whole it's based on, so much is based on science and so much is based on hope, and all of them, how they interact with each other, and how, as a treating oncologist, when you're sitting in front of the patient, how difficult these debates are, and you need to take them through it. But there's always that uh, that thought in the back of the mind when sometimes the test is not going to come up. So I think that's another thing, is when we sit with patients before we order the test, it's not that you do a blind NGS saying just do this and it's going to help. Whenever you order a test, you kind of tell patients, in this cancer, whenever you do an NGS, what are the chances of picking up some mutations? And the example you gave, head and neck cancer, is classically one of them, where in NGS, our mutation pickups for targeted therapies are very, very few. So if we do an NGS for head and neck cancer, we are telling our patients that it's very, very remote. It's a remote chance you're trying it on. Don't bank on it. Continue your treatment the way it's going on. Look for immunotherapy options. Look for other options. But this is just one of the remote chances. But if I'm doing it for a cholangiocarcinoma, there's still a 30% chance I will pick up some mutation. So that's where you kind of keep looking for new options. So I think communication is the key. Telling patients why you're asking for the test, what are you going to look for in the test, how you are going to interpret it, and what do you do if it comes positive, and what do you do if it comes negative. That communication is very important for both the oncologist and the patient.
And in fact, today's conversation that we are having, my aim is that when patients see this conversation, they are actually better equipped to ask those questions to their oncologist as to, as you rightly said, what are you looking for? Because if the oncologist doesn't know what they're looking for, then you're not going to find it. So that's the key. Now, you mentioned earlier about various types of these NGS where the number of genes can be varied, and also it has an implication on the cost. So is there a sort of loose algorithm that you use to decide in which patients do you use limited panel or in which patients you use the full panel?
Right. So 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 if there's a cancer with known actionable genomic abnormalities like lung cancer, where it's big in number, and we know which are the genomic abnormalities, and those are the 9 or 10 of them. In lung cancer, for many a times, we may get away with just a limited panel NGS, but we always say and tell patients, if we think there's a very high probability and a limited panel NGS is negative, please move it forward and go into another platform of NGS. Probably we are missing something on that. So that suspicion for a medical oncologist has to be very high. If you're getting a negative NGS on a limited panel, it may be a very cheap test compared to the others. But if your suspicion clinically is high, you need to escalate the test to one of those comprehensive NGSs and try and chase and find the abnormality. Now, one typical example I can tell you, in India, adenocarcinoma lung in females, we see a huge percentage. But we believe almost all of those non-smoker adenocarcinomas in females especially are all driven by some molecular abnormality. Now, if I did any NGS and I got it negative, I would be obsessed to go into the next level. I would think we are missing some abnormality. And so I would say, let's do a more broader NGS. Let's do an NGS which is also looking for DNA, but also looking for RNA, because DNA picks up a lot of mutations very well, but RNA picks up fusions, which we miss sometimes by the DNA NGS. So some fusion abnormalities we are seeing will be picked up by that. So we kind of escalate there and say, do a comprehensive NGS. Now, yes, we know comprehensive NGS can be expensive, and that's the reason why one in India especially, we just can't order a comprehensive NGS for all our patients. We need to be very, very aware of what the costing is happening, and especially when our chances if are very, very few, it always becomes a little dilemma. Ki, is this test worth spending for? But then it's a very it's a very dilemmatic situation for even oncologists, because you're hoping for those remote abnormalities, and believe me, some of these abnormalities are in the tune of only 1-2%. Now, a classical example is NTRK fusions. We say they're less than 1%. But NTRK fusions are not going to be picked up if you don't do a good NGS for it. So that's the reason why, there's this always conversation which happens with patients. When are you going to do a limited panel, where we can get away with it, where we should expand our panels? And nowadays, there are a lot of companies doing expanded panels to 50 genes, 70 genes, which are very good, which cover up most of the abnormalities which we want to. And yes, in spite of that, when we sometimes do a direct comprehensive NGS. Now, sometimes there's very limited tissue and you need a quick answer and you need one answer. There, sometimes we just do a broad, comprehensive NGS directly. We are not going to spend time going through these sequences when time is the key and time is the essence. So these are the nuances which work out while testing.
Other thing that I see again in clinical practice, which is slightly an uncomfortable thing, but it's a reality which we have to deal with, especially in India, which is the finances involved in this process. Because I guess one of the things that we need to also do is to assess what is the affordability of the patient. Because sometimes I've seen things where we ask for a particular test, an answer comes back, and then the patient says, but you know what, I can't afford this. They could afford the test, but they cannot afford the treatment. So I think that conversation also is an important conversation, where we tell the patient that, okay, if this comes positive and this treatment needs to be given, it's going to cost you this much. Do you really want to go ahead? Because I feel getting a positive report and then they feeling that, my mother is going to die because I'm just too poor to give that drug. That's a terrible thing to happen. We might as well not do that test at all. Have you seen such cases happen?
Yeah, I do think so. So cost has always been the major drawback for many of our patients in cancer treatment, and that's the reality of our situation. There are the major patient population is not insured, and they really cannot afford all the newer targeted therapies, which are very, very expensive. Now, the good thing in India is we have lot of targeted therapies which are generic and which also are inexpensive, which at least we are able to use in many patients. But again, there are many targets which don't have cheap drugs. So there's no doubt about what you're saying. That's where I said communication is the essence. Telling patients what
Absolutely.
you're doing, what are you looking for, what could be a possibility, and what could be a treatment option, again, which is accessible or not. One needs to be very, very upfront and clear with patients. We That's the reason you see nowadays the discussion with patients has become very extensive, especially the initial discussions when you're trying to explain the cancer. It's not so straightforward just saying, even as simple as when patients used to ask us for stage 4, now, what's my survival? You, we tell our patients, we just have a report saying an adenocarcinoma as of now, even if it's stage 4. But I just don't have all the information to tell you what's the survival going to be. It could be one of those good mutation profiles where survival can be very, very long with all these therapies, or it could be one of those bad ones where the survival is going to be very short. And without sequencing or getting all this information, we don't have the right answer. And that's why all these decisions, all these conversations have become very important. But 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 I agree with you fully. Getting some of those mutations, I think you treat a lot of brain tumors now. we keep saying IDH mutation in brain tumors has become so important, and it's so frustrating that you don't have an IDH inhibitor in India. And secondly, the IDH inhibitor which you're talking about from the West is so expensive. But but we are picking up these mutations. Of course, here we are picking it up just by doing a simple IHC test. But so many patients with brain tumors have IDH mutations, and these therapies are completely unaffordable for our patients in India. So that's the reality of our situation. But I also look at it the other way is, if we think of it long term, if we do the test and we have a base of what our patient profile is, when the drug comes in, you can immediately get them into it. Or if there's a clinical trial which opens up, some of these sequences, we keep this information. I can tell you, we have a few patients of some cancers where we have KRAS G12C as a particular mutation we have identified. And we know these drugs are looking for clinical trials in India. So we may open up and put these patients into a clinical trial for these. So getting this information, it's good to keep all this information. But yes, it shouldn't be outrightly do a very expensive test and tell patients, oh, we have something, but you can't afford it, so we can't do anything about it. That's not what we want, absolutely.
Yeah. And all these tests have also made us wiser as oncologists, because we are also starting to understand the profile of our patients. Because, like always, all the data that comes in from the West. And now, in fact, last few decades, we have started understanding that our population is very different from the Western population. Be it breast cancer, be it head and neck cancer, be it lung cancer, the profile of our patients and the mutations that they have and the way they react to their therapies is very different. So we as as oncologists also starting to understand these things better, and are able to offer better care to our patients.
Yeah, that's true. That's absolutely true. I think knowing our own patient profile, there's so much differences. You see, as EGFR mutation in the West is only about 10%. In India, the EGFR mutation status is 35% in lung cancer. So clearly, the mutation profile is different. Getting this information, understanding this, will help in the long run. And I kind of think all of us need to kind of, if we suppose we all of us understand that these are the mutations which are dominant in our patients, eventually we can push pharma companies to say these are requirements where the drug is required, kind of launch these drugs in India. And of course, we keep looking for newer options coming in, maybe even generic options coming in. So these are all things which will happen up if we know about it. If we don't know about it, then what will happen is we'll end up telling our patients, no, we just have chemo for you. And we'll end up giving chemotherapy for all our patients. And that's something we do a lot, but that's not where we want to be. We really want the care to move up to the next level where we are expanding and improving their survival and the quality of life.
Yeah. Cancer is now gradually becoming more like a chronic disease. Earlier, cancer was like the most terrible thing that happened to you, and either you survived or you died. But now, gradually, at least some of the cancers now are becoming very chronic. Even if you're not able to completely cure it, the patient may need a little bit of therapy in between, and life goes on, and life goes on with good quality of life. So, we are becoming more like a chronic care, chronic disease care sort of a team.
Absolutely. I think that's the best way we can tell our patients, And I think all of us, you and me, would be using this word, using this terminology so often. Diabetes is not cured, hypertension is not cured to our patients. So don't think of stage 4 cancer to be cured, but live with it, have a good quality of life, and continue your background treatment. Ovarian cancer, classical example. Some of these ovarian cancer patients treated for decades. You just go on and on and on, and you need to just take them through. Hormonal positive breast cancer patients, stage 4, you take them through for years of treatment. But I think emphasizing quality of life also is very important when we do this.
Absolutely. So we spoke about what is NGS and different types of NGS, but and you also mentioned which type of cancer should the oncologist prescribe the NGS to. But when should we do it? Should we do it at the diagnosis, in the middle of the treatment, at relapse? Which part of the journey the NGS actually fits in?
So this would depend on the type of cancer you're treating. Now, lung cancer at diagnosis, we say at stage 4 lung cancer, absolutely do it at diagnosis. You need that information because all your treatment decisions are going to be based on that. Now, if you talk of breast cancer, it's absolutely not necessary to do it at diagnosis. Most of our breast cancer patients just getting the IHC information of ER, PR, HER2/neu, and that information is enough for us to treat patients. So that's one place where we don't do NGS upfront. In breast cancer patients, we do NGS when you have progressions, when you're looking for new alternatives. That's where you start introducing NGS. If I'm thinking of stomach cancer, that's one place where we really don't need NGS upfront. IHC is good enough to pick up the MMR IHC, the HER2/neu, and now the new Claudin 18.2. So stomach cancer, we don't need it. But if you look at prostate cancer, NGS is becoming very important. That in advanced prostate cancers, you want to know whether they are BRCA mutants, somatic BRCA, whether they are HRR genes are abnormal. You need that NGS there. Ovarian cancer, you are doing HRD testing, and HRD testing is coming out from some form of NGS sequencing reports. So HRD testing upfront in ovarian cancer is very important. So these are cancers where it is important upfront, but in many cancers, it can be kept as a later line tool, especially where cancers where you have IHC based tests which decide your treatment. So, so I think in stage 4 patients, in progression, NGS becomes very important because you're trying to open up new opportunities. But in some cancers, like cholangiocarcinomas and gallbladder cancers, it's becoming important to do upfront NGS because those abnormalities, you may not get enough time to kind of get all that information in future. So it's better to get that information upfront. There's also the new thought, especially in some cancers like lung, which are EGFR. You kind of do an NGS, you treat them for years, they do well on some, maybe the oral therapy which you gave them, and then they progress, and then you do an NGS again to see why have they become resistant. So can I offer them newer drugs which overcome the resistance? So that's another place where NGS is becoming important in some situations.
Yeah. And this is a very important point. I think our viewers should notice that when you do a test, especially a test like NGS, it is valid at this point in time. But, suppose 2 years later, if you have a relapse, your tumor would have probably mutated in a way, it would have, have different mutations. It is behaving in a different way. And you would also have newer drugs by then. Every few months, there are new drugs coming up. So, patients do ask, "Oh, but we did it last time. Why are you asking it for again?" And that's because, it's a new war. We have to know the new enemy all over again. And we have to direct our therapies accordingly.
Right. You're absolutely right. We always say tumors are evolving, they are mutating. That's how they are developing resistance, and that's where you want to find out the new drivers or what's causing resistance. The one common mistake sometimes happens is you get a patient who's been treated for a few years, and then they come to us and we tell them now we need to do an NGS, and they say no. Oh, I have that old tumor block from 2 years ago. Let's do an NGS in that. And that's clearly we tell them, no, that information is not going to be very great for you now. It's the cancer would have evolved because you've been on treatment, and you need a new tissue to kind of get this new information of what's happening to the cancer now. Or when you don't have tissue, that's where blood NGS is coming into the picture, trying to help us in these situations a lot more.
Yeah, I remember we had one patient of lung cancer who was on treatment and had, was controlled. And then recently they presented with a sort of a very difficult location, para-aortic sort of lymph node in the mediastinum. And the interventional radiologist said, "I just cannot biopsy this. This is just way too risky." Patient had come to me for palliative radiation. We were thinking about SBRT. And it was difficult because the medical oncologists were very keen on knowing what's happening, and I think then he had a liquid biopsy, and that's how we got the answer. We are going to have another conversation on liquid biopsy, so I'm going to do one full episode on liquid biopsy because that has become also a very important conversation now with patients. That and sometimes patients are over enthusiastic. I want to do liquid biopsy to see how the tumor is, and we have to sort of tell them that you can't just use it like a regular blood test to see how your WBC count is. We can't do it that day. So I'm going to do that conversation also, so that it clarifies some questions in patients' minds. But from what you mentioned about when to do NGS, I think it's important for the viewers to understand that for many of the cancers, like you mentioned, breast cancer, ERPR positive, we have set protocols, and those set protocols are based on the evidence that we have. So we have treated millions and millions of patients. Clinical trials have shown that this is a treatment that is working in this population, subset of population, and we are using that. And when we sort of run out of those answers, or we feel that there could be more answers coming up, that's when we order for NGS. And NGS is not something that you do in most cancers, in most patients, upfront as the first test. It's something which is more nuanced, and your oncologist will actually tell you when to do it, and what answers do we expect and what treatment then we have.
Yes, correct. It's best to kind of discuss that with the oncologist and kind of find out, does NGS have a place in the treatment at present? But yes, most NGS tests come in later lines of therapy, except in some cancers where we really insist on doing it upfront, like lung cancer.
Yeah. And from the lab's point of view, now we have lots of options, right, when choosing a lab. Is there a particular protocol that you use to choose this lab versus that lab? Can patients have an understanding of how do we go about choosing the lab for doing NGS?
So that's a little difficult for patients to choose. I think it's difficult even for the oncologist to understand until they have really discussed this out with the lab to understand what kind of test the lab is doing, what have been their results over time, how have they validated the results, what is the lab's accreditation to say that their reports have been really accredited. So this I think is not going to be easy for patients. We tell patients that just don't go by saying this is the cheapest cost and do this, and this cost is not the only thing in NGS. There's a lot of nuances to the testing. But yes, I think the oncologists who ask for the NGS need to understand this information, and they need to communicate with the lab. If they get a report, they need to talk to the lab, that the molecular oncologist in the lab, to understand how that report is being interpreted and how important is that information which is coming out. So that's something that oncologists and the molecular oncologists have to discuss. Uh, it can be a little tricky because there are multiple labs in the country doing testing. There's always a competition of cost running in. It's good because cost. We have seen how NGS costs in the last 7-8 years. You've seen how it's dropped down more and more. It's become so accessible, and even by tweaking the gene panels, by looking at what's important for your patients, you have been able to reduce the cost. So that's really good for our patients. But we need to understand, if there's a cutting, there should not be missing out happening in the test, and that's the whole nuance of the test and interpretation of the test. So I think as that information comes on from the oncologist talking to the lab and molecular oncologist, and getting that information to be interpreted correctly for treating your patient. Eventually, we want to have the right information for this patient so that we can treat them best. And in precision oncology, if we have to be precise, the test has to be correct, because that's the thing you are running on. Your basis all your treatment on that test.
So I think from the patient point of view, I would say the most important part here is to get a very good precision oncologist involved in your care. And you need to really, really look for the best doctor that you have in your city or town where you are, who are experienced in managing these treatments, who are experienced in treating patients with precision medicine, and not somebody who's probably practicing general oncology for a long time and has now just started ordering tests. So I think it's important that you review your medical oncologist or precision oncologist, and take the right decision of going to somebody who's trained and who's also very experienced in doing these things.
Yes, that's really very important, because precision oncology by itself is changing so rapidly. Even oncologists who are treating with the precision uh, with this kind of precision therapies need to keep updating themselves very, very rapidly. Every year you'll hear there are multiple new tests which have come in, there are multiple new genomic abnormalities which have been identified, and there are multiple new therapies which are getting adapted into it. So you really need to go in to meet your precision oncologist, who's kind of looking at these patients and looking and treating them in that manner. And I think the good thing is, information is right out there. Now with the digital technology, everyone has that information, and that's the best thing about it.
Yeah, I think there is a lot of democratization that has happened about information, and patients also have a lot of information available at their hand. And of course, podcasts like this also help them to get that information better. And oh my God, we have to keep updating ourselves so much. I mean, I know my colleagues, Dr. Sevanti, whom you know well, she would share with us on our tumor board, this drug has come and that drug has come, and some of those drugs names we can't even pronounce. I said, We can't even pronounce this. How do you remember what to do with them? But that's the world we live in. It's very rapid changes are happening. And from the point of radiation also, we're now sort of seeing a lot of drugs which were immunotherapy, especially where we can combine precision radiation techniques such as SBRT and SRS, where we are seeing better outcomes with that. So we are also really excited with the way the changes are happening. I mean, I see now a lot of patients with brain metastases and bone metastases that are coming up. Now these patients were not coming to us earlier because they were not surviving. So now these patients, because of the very good systemic therapy, chemotherapy, immunotherapy, targeted therapy that they have, they are not only surviving, but they're surviving with excellent quality of life. So if there is some, relapse happens in the bone or brain, we are then able to do a very precise radiosurgery for that, ablate it, burn it out completely. Patient goes back to the drug, and then again, I don't see them for a year, 2 years, and that's the journey that many of our patients are having, and it's just wonderful to see.
Oh, it's a very very I would say a couple of things you said are very very important. So one is this integration of all of us together, the medical oncology, the surgical, the radiation. It's become so much more important. It was always there. We always said yes, we had tumor board discussions, but now the way the tumor board discussions are so much more integrated. Uh, you treat you take an example of cervical cancer. I think having integrated immunotherapy into cervical cancer treatment with radiation and then continuing it further, that's such a dramatic change. Or if you think of operable lung cancer, integrating neoadjuvant chemoimmunotherapy, downstaging, then the surgeon operating into it, and then giving treatment further. It's made such dramatic changes in the whole life survival of cancer patients. So integration of all oncology together, communicating with each other, having tumor board meets, understanding these new developments which are happening, and everyone working for the betterment of the patient. And that's what's happening in these tumor boards. And I think uh, using this technology in the right manner, and that's what's making the change for these patients.
Yeah, that's amazing. So where do we go from here, Dr. Amit? What's the future like?
I I think NGS testing is here. It's absolutely here to stay. It's just that there's always that talk of when to do it, would it be useful or not? How expensive is it going to be? These questions will always come up, but it's absolutely there for every cancer now. No, I think it's also going to move from that late line setting to early line settings for many cancers. I really see uh, no way people would treat cancer saying, no, let's wait for doing the NGS. The way times have changed so rapidly, we have seen that right happening there in just the last few years, that NGS will be the way forward. I also think NGS will help us choose better, not only in terms of like we're saying we have a targeted mutation. It could also help us prognostify a patient. A brain tumor with an IDH mutation is going to do much better than those who are negative. It will help us in telling prognosis. And also, when we're talking of immunotherapy, for using immunotherapy, we are getting NGS reports which tell us you have resistant mutations, so immuno may not work. So it's going to help us in every step of cancer treatment. So I think NGS is here to stay. It's very important for patients. It's important for the oncologist to understand about it and interpret it also better.
One of the questions that I get sometimes in social settings is people say, Doc, when are you developing a pill for the cancer? Do you think that's going to happen?
I think I
Just
think
pop a pill and cancer will be out.
I think cancer is just too smart. The cancer cells are so smart, the way they mutate. Yeah, I think you remember the time when Gleevec, imatinib came for the first time.
Yeah.
It was like the magic pill, the miracle pill for cancer. And it did it. It did it for CML, chronic myeloid leukemia, changed completely just with that oral tablet. But unfortunately, not all cancers are driven by that single mutation which can be targeted and which will cure patients. So it's going to be a lot of integration of various therapies together. It may be sequencing of therapies together. It may be pills in various forms, combining with other things, or moving from one pill to the other pill to the third pill. But there's a lot of advance happening. The amount of advance happening in oncology, it's tremendous. And I think it's good for patients, it's good for oncologists that they are able to do these changes for patients' lives.
Yeah. And for us as oncologists, I think it has given us so much joy because you can see your patients do well. You can see the quality of life being maintained. You can see them survive longer. You can see that smile on their face. They're getting and getting on with their life. And it's just so amazing to see that. It's just beautiful.
I cannot more reiterate that fact, that this change we would have never seen earlier. Just last week, we had a patient who had an adenocarcinoma lung with brain mets 10 years ago. And since the last 10 years, he's on an ALK tablet in sequences. That's it. Just on an ALK tablet and not a single other drug taken. He had three brain lesions 10 years ago, SRT given to those three lesions, and then ALK inhibitor tablets started. In the NGS, we found an ALK inhibitor, ALK fusion. We started the ALK inhibitor. At that time, it was the first generation ALK. He took it for a few years, then he progressed. Then we got into a second generation ALK. And with that, he's still continuing the last 7 years. So now, 10 years down the line, and I still know for him, I have a third generation ALK when it comes in and when it progresses. This is amazing the way it's changed patients' lives. And he leads a normal life. So that's the way cancer care has changed. Unfortunately, it's not for everyone. It's not for every patient. So that's the way one needs to kind of hope that we get good information, hope we get good treatments. But again, we need to understand the reality of cancer, the way cancer behaves in our body, and the way cancer cells can mutate, can change, and can develop resistance. And that's the reason why you keep trying to do the best you can.
Fantastic. So, on the note of that hope, Dr. Amit, I want to thank you very much for sparing your time and giving us such a detailed overview of what NGS is and what lies in future and how it has really impacted patients' lives. Thank you very much for joining us today.
Thank you, Dr. Prasad. It was a wonderful time chatting with you.
Thank you for joining us today. I hope you found today's episode very informative. Feel free to write your questions in the comment section, and Dr. Amit and I will answer them with correct information. Please do like and subscribe the video, but more importantly, share it with people you care for. Please join us in this fight against cancer. Thank you.